Hi, I'm Dr. Sumbul Beg, and this is Easy Endo Prep, Endo in a Bite. Your go-to no-fluff podcast, the perfect study snack for busy endocrinologists who want fast, board-relevant content that actually sticks. You can grab the full board review course at easyendoprep.com. Now let's walk through a practical, high-yield update on MASLD and MASH. One that's going to matter on both your board exam and in the clinic. And if you've signed up for our newsletter over at easyendoprep.com, we'll send you a direct link to the PDF. The actual show notes for this episode also include a few more key details, things that didn't quite make it into the audio but are still worth knowing. Let's get started. MASLD is now the overarching term, replacing NAFLD, and refers to hepatic steatosis in the setting of at least one cardiometabolic risk factor. If inflammation and hepatocellular injury are also present, that's classified as MASH. All right, so here's what I'm going to cover. I'm going to walk you through the board-centric educational objectives that consistently show up across major review sources. These are pulled from years of material, including EBR from 2019 to 2024, ESAP 2019 to 2025, ASAP 2022 and 2025, and also Cleveland Clinic 2022, Brigham 2023. This isn't just a random list. These are the high-yield themes that keep resurfacing year after year, and mastering these will absolutely move the needle for board success. And they will help you in the clinic as well. Let's talk about statin therapy. Here's what matters. Statins are safe and effective in patients with MASLD and MASH. They significantly reduce cardiovascular morbidity and mortality and do not worsen liver histology. Mild liver enzyme elevations seen with statins are typically transient and not predictive of hepatotoxicity. If a patient meets standard criteria for dyslipidemia or ASCVD risk, statin therapy is indicated regardless of fatty liver status. So when should we not start or at least press pause on statins? If the patient has decompensated cirrhosis, you want to avoid or use statins very cautiously. There's limited safety data here, and the risk of hepatotoxicity becomes more relevant. Next, in the setting of acute liver failure or active hepatitis, hold off until those liver enzymes stabilize. This isn't the time to be introducing a statin. What about elevated transaminases? If the ALT is more than 3 times the upper limit of normal and there's no urgent ASCVD indication, take a step back. Evaluate for other causes first. Once things settle, you can think about reintroducing, and then if there's severe statin intolerance, pivot to alternatives. Options like ezetimibe or PCSK9 inhibitors are on the table, and you can always consider a cautious rechallenge later on. Key points to keep in mind. Statins don't worsen liver histology. There's no need for routine liver function tests after the baseline check, unless something clinically points you there. And the big picture. MASLD is a cardiovascular disease equivalent in many of our patients, so the mortality benefit of statins far outweighs the risk in most cases. Now, the boards want us to know, in lean patients with unexplained hepatic steatosis, consider hypo-beta-lipoproteinemia, particularly if the LDL-C is low and there's a family history. Let's discuss who we should be screening for MASLD. If your patient has prediabetes, type 2 diabetes, obesity, metabolic syndrome, or PCOS, they're automatically in a high-risk group, and they should be evaluated. Also, any patient who has incidental steatosis picked up on imaging, that's a flag. Even if the imaging wasn't liver-specific, if steatosis was mentioned, it deserves follow-up. Now let's go over what we use to screen, both imaging and labs. From an imaging standpoint, ultrasound is widely available, but keep in mind, it doesn't do a great job picking up mild steatosis. That said, it can clue us into advanced disease. For example, if there's a nodular liver surface or splenomegaly, you should be thinking cirrhosis. Non-contrast CT can be more specific. If the liver attenuation drops to 48 Hounsfield units or less, or the liver to spleen ratio is under 1.2, that supports moderate steatosis. And then there's MRI-PDFF, which is the gold standard for quantifying hepatic fat. Anything over 5% fat fraction qualifies, but it's expensive, so we don't use it for routine screening. As for labs, we rely on basic tests to calculate a FIB-4 score. That score is based on age, AST, ALT, and platelets, and it helps us estimate the risk of fibrosis. So how do we interpret the FIB-4 score? If it's under 1.3 and the patient is under 65, they're considered low risk. If the FIB-4 is 1.3 or higher, then we move on to second-line testing. That's where FibroScan or the ELF test comes in. Now, the big question, when do we refer to GI or hepatology? Here's the checklist. If FIB-4 is 1.3 or higher and there's abnormal imaging, that's one reason. If FibroScan or ELF suggest intermediate or high risk, they need specialist care. If you're worried about MASH or cirrhosis, maybe their ALT and AST stay elevated, or imaging shows nodular changes or splenomegaly, refer. If liver stiffness is 25 or above, or even 20 to 25 with platelets under 150, that's considered clinically significant portal hypertension. If you're unsure of the diagnosis and need a biopsy, or you're about to start an advanced therapy or enroll in a clinical trial, it's time to bring GI in. So again, in the boards, we're going to have to know when to identify the right patients and use FIB-4 to stratify, and then follow up with FibroScan or ELF, and then refer when the data or the clinical picture points to fibrosis or uncertainty. And then there was a newer educational objective, diagnose MASLD in a lean woman with PCOS. Lean women with PCOS are at risk. PCOS is an independent factor for MASLD, likely driven by insulin resistance. Workup includes liver enzymes, non-invasive fibrosis scoring, and imaging. Diagnosis of MASLD still requires exclusion of secondary causes, such as alcohol, viral hepatitis, and hepatotoxic medications. Ultimately, diagnosis hinges on combining cardiometabolic risk factors with imaging or histologic evidence of steatosis. Let's shift to weight management, particularly in elderly patients and those with complex comorbidities. In older individuals with MASLD or MASH, a 5 to 10% weight loss is beneficial. But this must be individualized, accounting for sarcopenia and frailty. Approach should include supervised gradual interventions, not aggressive caloric restriction. For patients with coexistent ALD, management must be multidisciplinary. First, absolute alcohol abstinence is mandatory. Then, structured lifestyle changes, behavioral therapy, and support systems are key. Let's break down the weight loss targets and what they actually do for our patients. If a patient loses just 5% of their total body weight, that's already enough to trigger a meaningful reduction in liver fat. We're talking about a significant drop, around 30% or more, in steatosis just from that initial weight loss. So even small changes can make a real difference. Now, if they push further and hit 7% weight loss, that's where we start to see improvements in liver inflammation. It's no longer just about fat. Now we're changing the histology. And the biggest changes come at 10% or more. That's the level of weight loss where we actually start seeing fibrosis improvement. And in many cases, even reversal of stage 2 or 3 fibrosis. So bottom line, 5% drops fat, 7% improves inflammation, 10% can reverse fibrosis. That's the target ladder we should be aiming for. So when do we consider bariatric surgery? If the patient has a BMI of 35 or higher, that's a strong indication and they're clearly a candidate. If their BMI is between 30 and 34.9, it's a little more nuanced. but if they've got progressive disease, surgery should absolutely be on the table. Now, if there's stage 2 fibrosis or worse, or if you've got a patient with biopsy-confirmed disease who just isn't improving, this is someone to consider early for surgery. Don't wait for things to progress. The one place we really need to pause is with cirrhosis. If it's compensated and the patient is otherwise stable, surgery may still be an option. But in decompensated cirrhosis, or if there's clinically significant portal hypertension, then surgery is generally contraindicated. Let's talk about where we stand today with medications. Right now, there's just one FDA-approved treatment, and that is Resmetirom, brand name Resmetirom. It made history in early 2024 as the first medication ever approved for MASLD. So who qualifies for it? It's approved for adults with biopsy-confirmed disease who have moderate to advanced fibrosis, that's stage 2 or 3, but not cirrhosis. And just like most of our endocrine therapies, it's meant to be used alongside lifestyle changes, not instead of them. This is a selective thyroid hormone receptor beta agonist that specifically targets the liver. It promotes hepatic fat oxidation, reduces fat production, and enhances insulin sensitivity at the hepatic level, without triggering systemic thyroid hormone effects that would be seen with non-selective thyroid hormone therapy. Now, what about other options? There are a lot in the pipeline, but nothing else has full FDA approval yet. That said, we are already using other medications off-label. Let's start with the GLP-1 receptor agonists like semaglutide and liraglutide. These drugs have shown dramatic improvements in liver fat and inflammation, plus they bring the added benefit of weight loss and glycemic control. We're using them all the time, even though they're not formally approved for it. Pioglitazone is another option, and it's been around for years, and while it's mostly used in diabetes, it does have evidence for improving liver histology, especially in diabetic patients with active inflammation. Of course, we do have to watch for weight gain and fluid retention, particularly in older adults. Vitamin E also comes up in the non-diabetic population. It can improve inflammation and ballooning, but doesn't do much for fibrosis, and there are long-term safety concerns if used chronically. SGLT2 inhibitors are still being studied, but early signs are encouraging, particularly through metabolic improvements that indirectly benefit the liver. Now, looking ahead, there are several promising agents in phase 3 trials. Drugs that target both the GLP-1 and glucagon receptors. These may eventually reshape how we treat this disease. We're also seeing early data suggesting that combination therapy might be the way forward. Let's quickly recap. Statins in MASLD, not just allowed, they are preferred, do not hold for elevated LFTs unless there is decompensated cirrhosis or acute liver failure. Lean patients with a family history, low LDL, think hypo-beta-lipoproteinemia, know the association of MASLD. And then in the boards, you should know when to choose. What's the next step? FIB4. What's the next step? ELF or FibroScan. When are we screening? When are we doing the next step? And when are we referring to gastroenterology? I have seen many board review questions where they're asking us to initially screen with FIB4, or if the FIB4 is more than 1.3, now we have to do ELF or FibroScan, or if the patient is just beyond our capacity, high-risk patient, advanced fibrosis, or suspicion of progression, refer to GI without delay. They also definitely want us to know that PCOS is a recognized risk factor for MASLD, and in the treatment overview, weight loss 5 to 10%, coexisting alcohol use, or suspected alcoholic liver disease, advise complete alcohol cessation, bariatric surgery indicated if BMI equal or more than 35. Only FDA-approved med is Resmetirom, and it is approved for non-cirrhotic MASH with fibrosis stage 2 or 3. Off-label options, GLP-1 receptor agonists, pioglitazone in type 2 diabetics, vitamin E in non-diabetics, SGLT2 inhibitors under investigation. There, I presented MASLD to you in a nutshell. And thanks for tuning in to Easy Endo Prep Endo in a Bite. I covered key updates that matter for both board prep and everyday practice. Until next time, stay curious, stay consistent, and keep it bite-sized.